Dr. Suchard here again. This video discussion is going to be about phencyclidine and ketamine, corresponding to Chapter 82 in the Goldfrank's Toxicologic Emergencies textbook. The learning objectives for this session are that you'll be able to describe the expected clinical findings seen with phencyclidine or ketamine toxicity and to explain their mechanisms of action. To start off, phencyclidine and ketamine are structurally similar compounds that were developed initially to be intravenous anesthetic agents. But they're different from many of the other anesthetic agents because patients will still maintain muscle tone and generally maintain their own airway rather than needing endotracheal intubation and mechanical ventilation. The kind of anesthesia you can achieve with phencyclidine or ketamine is called dissociative anesthesia, where there is a dissociation between the patient's body and their mind such that you can do invasive procedures but they just won't respond because their perception and consciousness are just not connected with what's going on with their body. Phencyclidine was developed first, but was abandoned for human therapeutic use because of a high incidence of post-operative psychosis and dysphoria. More about this a bit later. Phencyclidine started becoming a popular drug of misuse in the 1960s. It's gone by many different street names, including the peace pill, which incorporates its common initialization of PCP, which stands for phenylcyclohexylpiperidine. It was commonly called angel dust in the 1970s, and while it's significantly less common today, it's still around. One of the PCP trends in the late 90s or 2000s was wet, sometimes called illy or sherm, which were marijuana cigarettes that had been treated with what was called embalming fluid. Now, actual embalming fluid is formaldehyde, which would be a stupid chemical to use to get high. But apparently, in at least some cases, PCP was added to a solution containing formaldehyde, and that was applied to the cigarettes. Interestingly, they were called Sherm because the treated marijuana cigarettes somewhat resembled the Nat Sherman brand luxury tobacco cigarettes. Today, ketamine is a popular drug of abuse or misuse because it produces some hallucinatory effects and out-of-body experiences that some people find enjoyable. Ketamine goes by several street names, including Special K. And depending on the dose taken, the user can have different degrees of intoxication. Some users are looking to get into the K-hole, a dissociative pit beyond consciousness. And I imagine that's exactly where I'm putting patients when I'm using ketamine for procedural sedation in the emergency department. While I'm only focusing on PCP and ketamine, you should know that there are many designer analog drugs out there as well. These are minor chemical modifications that all fall into the same aryl cyclohexylamine class. Dextromethorphan has a very similar structure and shares some similar properties. And it's because of these similarities that some people, usually teens and young adults, who can't access the illicit drugs they might prefer, will take large overdoses of dextromethorphan from over-the-counter cough and cold medicines. And the biggest dextromethorphan dose per volume OTC drug out there is Coricidin Cough and Cold with 30 milligrams per pill. This gives the product the street name of Triple C's. The primary mechanism of action of ketamine and PCP is NMDA receptor blockade. NMDA is N-methyl D-aspartate. The NMDA receptor is a type of glutamate receptor, and glutamate is one of our primary stimulatory neurotransmitters. So it makes sense that blocking this stimulatory signaling will result in CNS inhibitory effects on behavior, sensation, and cognition. Ketamine and PCP do not compete directly for the glutamate binding site on the NMDA receptor. Instead, they bind to a site within this receptor's pore, blocking the flow of ions that would result in depolarization and generation and propagation of an action potential. But with increasing doses of ketamine and PCP, you will see effects on other receptor systems too. If we're blocking primarily NMDA receptors, this produces analgesia and anesthesia, which are the desired therapeutic effects. Monoamine oxidase is also inhibited, producing a number of sympathomimetic side effects like hypertension and tachycardia. And at higher doses, we'll see agonism at sigma receptors and cholinergic and GABA receptors, producing sedation, lethargy, and coma, putting someone into the K-hole. PCP users have been reputed to be able to perform superhuman acts of strength, like jumping from significant heights and being able to fight off large crowds or the police. Certainly, these patients can be perceiving things weirdly and act as if they feel they are invulnerable, and they may have a sympathomimetic toxidrome picture going on contributing to their agitation, and they won't be feeling or processing pain normally due to the drug's anesthetic properties. Not a very safe combination, but fortunately this is not a common way that these patients present. The common clinical findings seen with PCP and ketamine intoxication include nystagmus, rapid, uncontrollable eye movements. For instance, on the emergency medicine and medical toxicology board certifying exams, if they were trying to describe a patient with PCP toxicity, they'd present a patient who looked like they were sympathomimetic and then also mention that the patient had nystagmus. Since our eyes can look in all sorts of directions, it's possible to have different directions of nystagmus too. I'm going to show about 40 seconds of clips from YouTube videos demonstrating different directions of nystagmus, any or all of which might be present with PCP or ketamine. My personal experience with ketamine patients is that I've seen horizontal nystagmus most often. Other common clinical findings relate mostly to the degree of sedation. The patient may have ataxia, an abnormal gait, assuming that the patient is awake enough to even try to walk, and then deeper and deeper CNS depression. But breathing generally continues even with very deep sedation. Treatment for PCP and ketamine overdose is symptomatic and supportive. There is no antidote, and generally all that needs to be done is to watch the patient as they recover spontaneously. Some additional things to look for that may affect pharmacologic treatment include hypersalivation. With higher doses, some cholinergic muscarinic agonism can be going on, producing more saliva and secretions. Antimuscarinic agents might be considered if this gets bad enough. I've seen hypersalivation and even some increased eye tearing in patients I've treated with ketamine, although it's never been bad enough to need any specific therapy. And there is also the potential for an emergence reaction as the patient is recovering. The patient might still be disoriented and hallucinating as they are nearly awake, and they can get anxious and agitated and act out. This can be treated with various sedating agents if it occurs. And if you remember back to the beginning of this video, these emergence reactions sound like why PCP was abandoned as an anesthetic agent several decades ago. Okay, now we're finished talking about PCP and ketamine. I'll be seeing you around.